Chapter 22, the ankle and foot. So when we think of the ankle and foot, we have to remember that they are bearing our weight in standing, but we want to have limited muscle expenditure. And so we have to have pretty stable surfaces or structures at our ankle and foot joints. But we also have to have pliability because our foot has to be able to adapt to different ground surfaces. And so the joints of the ankle and foot are designed to provide both of those things. So in order to provide both this stability and this pliability, we have several joints of the ankle and foot. And so we have a pretty stable structure mortise with our tibia and fibula, and where they're joined at the distal connection there as they meet with the talus. And so that's going to be our talocrural joint to make our ankle joint. And then the joints of our foot, we can see help divide into our hind foot, midfoot, and forefoot. So our talus and calcaneus are going to make up our hind foot. Our midfoot is going to consist of our navicular, our cuboid, and our three cuneiforms. And then our forefoot is going to consist of our metatarsals and the phalanges if you want to count the toes as part of the foot, but I think the toes are separate. Primary motions of the ankle and foot, this should be a review from Knies. So in the sagittal plane around a frontal axis, we have dorsiflexion and plantar flexion. In the frontal plane around a sagittal axis, we have inversion and eversion. And in the transverse plane around a vertical axis, we have ab and adduction. Together, those motions create our triplanar movements of the foot and ankle. So pronation is composed of dorsiflexion, eversion, and abduction, and supination is going to be plantar flexion, inversion, and adduction. So functionally, our tibiofibular joints help contribute to ankle motion. Anatomically, they are completely separate. We have a proximal and a distal, or a superior and an inferior tibiofibular joint that have minimal motion at them, right? Those bones lie in pretty close approximation to each other and aren't designed to necessarily have a whole lot of movement, but we know that we have rotation of the tibia that we have to be able to give way for. And so the functional need for our tibiofibular joints is going to be to provide accessory movements that help to increase the available range of motion at our talocrural joint. Our ankle is going to be our talocrural joint, and that's where our tibia and fibula meet with our talus. And then our subtalar joint is where inversion and eversion happen, and that is going to be where our talus articulates with our calcaneal joint, or our calcaneus rather. So the motion that we're looking at primarily happening at our talocrural joint is going to be plantar flexion and dorsiflexion. Inversion and eversion are going to happen at our subtalar joint. When we need to increase our plantar flexion or dorsiflexion, we're going to provide mobilizations in the direction of the arthrokinematic glide of the bone. So if we're looking at open chain mobilizations, where we would be mobilizing the talus to increase dorsiflexion, the convex talus rolls anteriorly and glides posteriorly. So we would apply anterior to posterior glides of the talus. In order to increase plantar flexion, the convex talus rolls posteriorly and glides anteriorly. So we would provide posterior to anterior glides of the talus to increase plantar flexion. For closed chain mobilizations, that's going to look at us moving the tibia and the fibula. So in order to increase dorsiflexion for closed chain motions, we see the concave mortise roll and glide anteriorly on the talus, and so we would provide posterior to anterior mobilizations of the tibia and fibula to increase dorsiflexion. If we're looking to increase plantar flexion, we're looking at the concave mortise rolling and gliding posteriorly on the talus, and so we would apply anterior to posterior mobilizations on the tibia and fibula to increase plantar flexion. Because we have so many joints, we see a lot of ligaments to help support the foot and ankle. And so looking at this first picture on the left here, this is going to show our medial ankle, and so this is going to be our first metatarsal here that you can see closest in this picture. We can also note it by the tibia being closer to us, but our medial ligament is made up of 4 different ligaments that compose the deltoid ligament, and those help to prevent eversion. And that's part of the reason that eversion sprains are less common, is because we have this really strong deltoid ligament on the medial aspect of our ankle that helps to restrict that direction of motion. Looking at the same picture, the ligaments shown on the bottom, we've got our spring, short plantar, and long plantar ligament. These are going to help provide arch support in standing positions, with our spring ligament being the most important of these three. If we move over to the top right picture, this is a lateral aspect picture. We can see our posterior talofibular ligament, our anterior talofibular ligament, and our calcaneofibular ligament. These three are going to be our lateral ligaments that help to restrict inversion, and they are not as strong as our deltoid ligament. They are nicely named, though, for where they run. So our posterior talofibular runs from the talus to the fibula on the posterior aspect. Our anterior talofibular runs from the talus to the fibula on the anterior aspect, and our calcaneofibular runs from the calcaneus to the fibula. Looking at the ligaments down on the bottom here, we can see our crural tibiofibular interosseous ligament. That's going to be the one that's involved in high ankle sprains. We can also see our deltoid ligament on the medial side and our calcaneofibular ligament on the lateral side. We also have these ligaments that run between the talus and calcaneus that help to support inversion and eversion. Looking at our joints of the foot, our talonavicular joint is going to be what separates our hind foot from our midfoot, and this joint helps to allow our foot to adapt to the ground surface and absorb shock so that we're able to maintain balance and joint integrity throughout the entire kinematic chain. Our transverse tarsal joint is going to separate our forefoot from our midfoot there. I got a little confused for a second. But that's going to, again, separate into our different parts. And this is going to provide, again, more of that mobility to conform to the ground. So a little bit less shock absorption, but more mobility. And then looking into our metatarsophalangeal and interphalangeal joints, they're more approximated than our joints of the hand, just based on shape alone, and that helps to provide the stability, but they do have that gliding motion that allows for the foot to conform to the shape of whatever it's standing on. It's important that we are able to maintain range of motion at these joints so that we're able to have the stability. A fixed foot, whether that's hind foot, midfoot, forefoot, is going to have decreased adaptability to the ground surface, and therefore balance is going to be challenged. We also need appropriate range of motion for things like gait, and toe extension is going to be more important than toe flexion because of the range of motion needed for those things. Structurally, we need movement in multiple areas to get the motions that occur at the foot and ankle. And so we have an interdependence of leg and foot motions. When we look at subtalar pronation, we need to see internal rotation of the tibia that occurs in order for both to happen. So one causes the other, and both are needed to support full range of motion. We can contrast that with foot supination that requires external rotation of the tibia, again, one causing the other. The arches of our foot help to provide support, and the primary support ligament we talked about earlier is going to be our spring ligament. But we also need the arches of our foot to be in the appropriate shape, because when they are, we have this keystone that creates this rigid shape of our foot, and that helps to create this rigid pivot for gait. So we need our foot to be adaptable and flexible to adapt to the ground so that we can maintain balance, but then we also need it to reposition itself and maintain these arches so that we can have this rigid pivot point to push ourselves forward on when we're taking a step. Abnormal foot postures that we can see that are, again, going to affect things up and down the kinematic chain. So pes planus is going to be a flat foot where we have an increased pronation to the foot, and that's going to be associated with internal rotation of the lower extremity. Pes cavus is going to be a supinated foot, so that's going to be associated with external rotation of the lower extremity. When we see the internal rotation of the lower extremity associated with pes planus, we often can see genu valgus as a result of that internal rotation of the tibia. When we are looking at pes cavus, or that supinated foot, or that high arch, we can often see a genu varus. Hammer toes are another postural deformity that are going to impact our gait pattern. Hallux valgus is where our big toe is going to point laterally and, again, create a different pivot point for gait when we're looking at that rigid rocker, and this can impact our functional mobility and overall efficiency of gait. And then forefoot varus or valgus, if we have our forefoot that's positioned either pointed medially or pointed laterally, we're going to get a compensatory motion at the hind foot to help create a straighter orientation there. So with forefoot varus, we're going to see more of a pronated foot to help compensate with that, and for forefoot valgus, we're going to see more of a supinated foot. This slide just kind of gives you visual representation of the things that we just talked about, but if we start down at the foot, we can see excessive pronation of the foot, so we have the collapsing of that arch is going to lead to internal rotation of the lower limb with the knee moving inward, and that's also going to potentially result in this anterior pelvic tilt, and we can see all of the postural areas where it can affect our shoulder position, our hip position, our knee position, and our ankle position. And so we have to remember that these things are all part of a kinematic chain, and when the body is out of alignment in one area, it's going to tweak the alignment of another area in order to try to restore this global alignment. You guys will also explore these foot patterns in the gait lecture, but this just gives you kind of that visual representation of what a normal footprint would look like when taking a step in a normal arch versus pes planus, where that's that flat foot. We see decreased arch in the middle picture there, or pes cavus, that's that high arch in the far right picture. Muscles of the ankle and foot, we're going to talk primarily about our plantar flexors and our dorsiflexors because of the angle of orientation of those muscles, right? Our primary plantar flexors are going to be our gastroc and our soleus, and because of their line of pull, that's the only motion that they produce. But we also have secondary plantar flexors that contribute to plantar flexion, but they're not the prime movers. But because of their line of pull, they also produce these other motions, and we'll talk about that more in just a minute. We have our dorsiflexors that are contributing to pulling our toes up, and those are going to be innervated by our common fibular nerve. Our intrinsic muscles are the muscles that do not cross the ankle. So similar to the hand where we have intrinsic and extrinsic muscles, our extrinsic muscles cross the wrist and our intrinsic muscles do not in the hand. Same thing for the foot. We have intrinsic and extrinsic muscles where our extrinsic muscles cross the ankle, our intrinsic muscles do not, and our intrinsic muscles serve as support to the arches during gait. During static standing, the line of gravity falls anterior to the ankle joint. So this means that gravity is going to push us into a dorsiflex position unless we have some kind of muscle activation to hold us upright. The soleus acts as the primary stabilizer to counter gravity during that static stance. So this chart just kind of breaks down the motions and the muscles responsible for that motion at the ankle. We can look at our plantar flexors with gastroc and soleus being our primary plantar flexors, but the other muscles listed there are going to be our secondary plantar flexors where they contribute to the motion, but they're not the primary muscle involved. Same thing for our dorsiflexors where tibialis anterior is going to be our primary dorsiflexor. The other muscles there contribute to dorsiflexion, but they're not the primary muscles involved. We can look at inversion, eversion. Inversion is one of those motions that's not necessarily produced in a straight plane by any one of those muscles. It requires the combined motion. So we can look at how we have tibialis anterior and tibialis posterior, both of which contribute to opposing muscle actions, but when utilized together produce this inversion in a different plane. And then our everters are going to be our peroneals or our fibularis muscles, because those are all going to be located on the lateral aspect of the leg. So all of these joints, all of these muscles, they serve to provide a function for the foot and ankle, right? And gait is probably one of our best examples of function for the foot and ankle. And so when we talk about gait, we need to, again, understand that we need adaptability and stability for all of the goals of gait. So when our foot contacts the ground, we're in a supinated position because that's going to hold the bones in a more rigid position for stability to receive that initial contact. As the foot lowers down, it's going to adapt or adjust into a pronated position in order to adapt to the ground surface and help to maintain balance. But as we bring our body forward over top of the foot, our foot is going to return to a more supinated position so that we have that rigid plank for efficiency during toe off. We've talked about this picture before, and again, you guys will go over this more in gait, but this just kind of gives you a good demonstration of which side of the ankle is active during which phases of gait in order to provide the stability needed. So we can see during that initial contact, we have activation of our tibialis anterior so that we can have eccentric control of lowering the foot into a plantar flex position so that we don't have what we would call foot slap or foot drop. We then get activation of our gastroc soleus as we come over to mid stance, and we're needing to initiate concentric plantar flexion in order to push off. And so we can just see the evolution of muscle activation and how muscle activation of the ankle is needed in order to perform stable gait. On top of appropriate muscle activation, we also need appropriate range of motion. So this chart breaks down your range of motions that are needed at a minimum for a normal gait pattern. So at the hip, for flexion and extension, we need at least 30 degrees of hip flexion and 10 degrees of hip extension. At the knee, we need 60 degrees of flexion and at least 0 degrees or a neutral knee for extension. The ankle, we need 7 to 10 degrees of dorsiflexion, 20 to 25 degrees of plantar flexion, and 5 to 8 degrees each of inversion and eversion. And then our great toe, we need 55 to 60 degrees of great toe extension. And we can see of the joints listed here, that's the greatest percentage of total range of motion required, and that kind of helps to emphasize the importance of toe extension range of motion. Major nerves we're going to talk about. So our common fibular nerve branches off of our sciatic nerve, wraps around the fibular head to innervate the anterior aspect of our shin to get to our dorsiflexors. Our posterior tibial nerve branches off of our sciatic nerve to travel down the posterior aspect of our leg to innervate our plantar flexors. Our plantar and calcaneal nerves are going to branch off of our posterior tibial nerve to innervate the foot. Common sources of segmental sensory reference in the foot, so where we are going to have something being damaged that's giving us pain or problems in the foot and ankle region, but it's not actually there, are going to be our nerve roots L4, L5, and S1. Management of ankle and foot disorders and surgeries. So we'll kick this section off with joint hypomobility and our non-operative management. Common pathologies that we can see related to joint hypomobility are going to be RA, which is typically going to affect the forefoot early on and might progress to the hindfoot, but it's typically going to affect those more distal joints first. Degenerative joint disease or osteoarthritis, joint trauma, post-immobilization stiffness, or gout, which is a pathology related to uric acid within the joint. Things that these patients are going to have a hard time doing. They're going to have restricted motion and alignment deformities. They're probably also going to have muscle weakness and impaired balance and postural control with an increased fall risk and difficulty with weight bearing because it causes an increase in pain, and gait deviations with decreased ambulation and oftentimes translating into other areas of function like transfers. During the protection phase for these patients, we're going to educate them on how to protect the joint, maintain motion as much as possible without increasing pain, relative rest, all of those things, and provide joint protection with orthotics as indicated. We want to help them decrease pain with this education and utilization of modalities as needed, and maintain joint and soft tissue mobility and muscle integrity with pain-free range of motion and range of motion of uninvolved joints and soft tissue mobilization and joint mobilizations as indicated. During the controlled motion and return to function phase, we're going to increase joint play and accessory motions, so we really want to get into movement at the bone level with joint mobilization techniques, and we want to improve joint tracking of the talocrural joint. So we can do things like mobilization with movement, where we provide a mobilizing force as the patient actively moves through that direction. We can do this for plantar flexion or dorsiflexion. During the controlled motion and return to function phases, we want to increase the mobility of our soft tissues and muscles with manual stretching, passive range of motion, self-stretching, joint mobilizations, and soft tissue mobilization. We want to regain a balance in muscle strength and prepare for functional activities, making sure that we have balanced muscle firing and muscle strength. We want to improve balance and proprioceptions. We need to progressively decrease our upper extremity support in order to make these things the most effective. So when we put our patients in positions that are going to challenge their proprioception, we can start them with upper extremity support in order to get them accommodated to the position and allow for the appropriate muscle activation. But in order to see real effectiveness from these interventions, we need to progressively decrease that upper extremity support until they're doing it without holding on to anything. And we also want to focus on developing cardiopulmonary fitness, especially if they've been deconditioned from an inability to do activities. Total ankle arthroplasties, or a TAA. Post-operatively, we need to consider immobilization and weight-bearing considerations as indicated by the patient's protocol. Some patients may be immobilized for 2 to 6 weeks. Some may be immobilized in non-weight-bearing for up to 12 weeks. It's going to depend on what the patient has going on. During the maximum protection phase, which is typically going to last 6 weeks in a TAA patient, we want to provide patient education regarding their infection and DVT risks. We want to do functional training with assistive devices, making sure that we're teaching them how to do things in compliance with their restrictions. So utilizing their immobilizer, whether that's a cam boot or a cast or whatever the case may be, and their assistive device to maintain weight-bearing restrictions as indicated. We want to start with ankle isometrics, active range of motion of the toes, and passive range of motion as indicated by their protocol. Again, default to the surgeon's protocol. During the moderate and minimum protection phases, we want to make sure that we're pushing to achieve 100% of the intraoperative range of motion. So we're going to do manual stretching, passive range of motion, all of those fun mobility things. We're going to start with open chain progressive resistive exercises and progress them to closed chain progressive resistive exercises. We want to do bilateral, progressing to single leg balance on stable and then progressing to unstable surfaces so that we can stress proprioception and balance for these patients. And we want to engage them in return to function activities so that we can restore them to their prior level of function. Arthrodesis of the ankle and foot. So instead of going in and replacing the joint, this is where they go in and fuse the joint. We can see arthrodesis of the ankle, arthrodesis of the hindfoot, arthrodesis of the first toe, arthrodesis of the IP joints of the toe, and all of these are going to be done when there's a lack of stability that limits function, increases pain, all of those detrimental factors that say, okay, this isn't worth trying to put up with anymore. Post-operatively, we're going to again consider immobilization and weight-bearing considerations indicated by their protocol. Depending on which joint they had fused and the surgeon's preference, they're going to have differences in those, and so we need to follow the protocol. Exercise considerations are going to follow those similar to a fracture because we're waiting for bony union, similar to when we have a fracture that we're waiting to heal. And so the patient's likely to be immobilized and only able to perform light isometrics and mobilization to the joints surrounding the tissue. Scratch that, mobilization to the tissues surrounding the joint that are permitted within the protocol. Other non-surgical conditions that we can see can include heel pain, tendinitises, tendinoses, and shin splints. So we start off with heel pain. We've got plantar fasciitis versus insertional Achilles tendinopathy and bursitis, and we can differentiate between those based on how they present. Plantar fasciitis patients are going to experience pain that's worse when they first stand up after they've been sitting down for a long time. That pain is going to gradually improve as they're in a weight-bearing position and they have this prolonged stretch to the plantar fascia until it reaches its threshold and it starts to increase in pain again because of the irritation. Comparing that with our insertional Achilles tendinopathy and bursitis, these patients are going to have pain that doesn't necessarily change with their weight-bearing status, and they're going to have pain with passive dorsiflexion or active plantar flexion where we are engaging that tendon. Our tendinosis, tendinitis, and tenosynovitis are going to be related to any of our tendons that cross into the ankle, so any of the muscles that we've talked about can be irritated, but the treatment for them is going to be essentially the same. And shin splints can occur anterior or posterior. These are a result of microtraumas, typically due to inaccurate or insufficient strength in the musculature and insufficient range of motion for required mechanics, typically running being the associated functional mobility activity. These patients are going to be pain limited, typically have hesitation or resistance to weight bearing that we have to educate them on retraining. There's balance deficits that present as a result of inappropriate muscle firing or muscle weakness, and we can also see range of motion deficits and compensatory movements. They're going to be restricted in our functional mobility tasks that require moving and standing, so our gait, transfers up and down stairs, work-related activities that require standing, those types of things. During the protection phase for these patients, we want to provide soft tissue mobilizations to the area of the lesion. So where they're experiencing injury and tightness, we want to provide soft tissue mobilization around that. We're going to have them perform submaximal muscle setting exercises. We'll do manual stretching of the plantar flexors, active range of motion within a pain-free range, and activity modification and educating them on relative rest. During controlled motion and return to function phases, we want to educate the patient and provide home exercises that help build the stability in both the intrinsic and extrinsic muscles of the foot and ankle. We want to increase the mobility of the range-limiting structures with passive range of motion, manual flexibility, joint mobilizations, and muscle retraining, and improve muscle performance, also making sure that we're not limited to just focusing on muscle performance in regards to strength and endurance, but that we're also looking at muscle firing with proprioception and balance activities. An ankle sprain is going to be what is typically considered the most common type of soft tissue injury that happens throughout our general population. Most of them are going to be managed non-surgically, and during the protection phase for those that are managed non-surgically, we want to provide patient education on price so that they're able to protect the joint. And we want to educate them to restrict weight bearing to tolerance, but increase weight bearing as tolerated, not to necessarily baby the extremity. We want to provide passive range of motion in a pain-free range so that we are preventing things like muscle guarding and further restrictions to range. We want to have the patient do active range of motion of their toes and submaximal muscle setting exercises of the ankle muscles in order to promote proper muscle firing. During the controlled motion phase, we'll provide soft tissue mobilization to the muscles surrounding the joint in order to address any limitations to range of motion. Again, joint mobs for range of motion limitations and manual stretching for range of motion limitations. We'll initiate open chain active range of motion exercises, coordination exercises, and intrinsic muscle strengthening exercises, typically looking at things like our toe curls, picking objects up with the toes. That's going to help target our intrinsic muscles. And then we're going to focus on gait training so that we can normalize any gait deviations. As the patient improves, we want to progress to resistance exercises and balance and proprioception, because balance and proprioception are going to be two of our biggest areas of deficit for patients with ankle sprain. Whether that's a single ankle sprain, this is the first time it's happened and their body needs improved proprioceptive training to recover, or it's a chronic ankle instability where this is a recurrent ankle sprain, they need the proprioceptive training for proactive prevention. During our return to function phase with these patients, we want to do closed chain strengthening and functional movement patterns, increasing the challenge to proprioception with unsteady surfaces, decreased upper extremity support, and or removal of visual support. If that sprain was serious enough to require surgery, then we need to look at our immobilization and weight-bearing considerations, because those are going to be protocol dependent, and we want to make sure that we are being patient-specific. During our maximum protection phase, we're going to initiate submaximal muscle setting exercises in order to promote proper muscle firing while the tissues are immobilized, or while the joint is immobilized for the tissues to heal. We want to perform pain-free active range of motion within our permitted range, depending on our protocol. We'll have active range of motion of the toes and knees and hip to make sure that we hit all of the surrounding joints. We want to have functional training in compliance with the restrictions, so staying within our weight-bearing restrictions, but trying to promote as much function as we can within those limitations. And we'll initiate progressive resistive exercises of the hip and knee, like we talked about, making sure that we hit all of the surrounding joints. During our moderate and minimum protection phases, we want to do manual stretching so that we can increase joint mobility, joint mobilizations to increase joint mobility. We're going to progress our active range of motion, initiate ankle PREs in all directions, starting with our open chain and then progressing to closed chain. We want to do proprioception and balance training, plyometrics, agility training, and gait training. We can also see surgical intervention following rupture of an Achilles tendon. Surgery is going to be indicated when we have a complete rupture, and we can see this clinically with the demonstration of a positive Thompson squeeze test or an abnormal Thompson squeeze test. And this is the test where you have the patient in prone and you squeeze their gastroc, and we expect to see their foot kick into plantar flexion as a result of us squeezing that muscle. But when we have rupture of the Achilles tendon, there's nothing to attach to the foot to cause that foot motion to happen. And so a positive or abnormal Thompson squeeze test would be squeezing the calf and seeing no motion happen at the ankle. Post-operatively, again, these patients are going to have a protocol, so we need to look at what their immobilization restrictions and requirements are and what their weight-bearing restrictions are so that we can design our treatment plan to be in compliance with that. During our maximum protection phase, we'll do functional training in compliance with those restrictions so that we can make our patient as functional as possible, including things like bed mobility transfers, gait training, stair training as indicated based on their need. We want to maintain range of motion of our non-immobilized joints by promoting active range of motion activities there. We'll do submaximal muscle setting exercises, initiating with our plantar flexors last, because we don't want to have activation of the tendon that's being healed until we have sufficient healing that's occurred. So we'll start with our dorsiflexors, inverters, everters for those submax isometrics, saving our plantar flexors for typically like 3 weeks out. We also want to do active range of motion within the protected range, again, following the patient's protocol. We typically aren't going to pull them into dorsiflexion past neutral if we're even allowed to get to that with their protocol, but we are going to be permitted some range of motion different than like a rotator cuff repair. We also want to do weight shifting with these patients, again, in compliance with their restrictions, but we want to get them used to tolerating weight on the extremity and promoting muscle firing with that weight-bearing approximation muscle firing input. During our moderate protection phase, when we don't have to be as protective of our tissues, we will initiate manual stretching, again, looking at our protocol to make sure that we're staying within the allowed movements and ranges of those movements. We'll do ankle active range of motion with unsteady surfaces, things like our BAPS board or a wobble board, having the patient try to control that unsteady surface so that we can kind of promote these more closed chain positions. It's still an open chain movement because it's the distal segment moving, but it's preparing the foot for those closed chain activities and the coordination required in those closed chain situations. Open chain progressive resistive exercises for the hip, knee, and ankle as indicated by the ankle. Remember, hip and knee we want to protect the strength and integrity of while everything's healing. The ankle we will initiate per the patient's protocol. We'll do closed chain progressive resistive exercises as permitted, complying with weight-bearing restrictions. We will do balance and proprioception exercises, progressing from stable surfaces to unstable surfaces and decreasing the sensory input, including closing the eyes to increase proprioceptive challenge as the patient is able to tolerate. We'll do gait training to normalize any gait deviations and aerobic endurance activities because these patients have not been able to participate at their normal level for a prolonged period following the maximum protection phase. During our minimum protection and return to function phase, we want to have the patient independent in their maintenance of range of motion with a lot of self-stretching and self-mobilization activities. We want to promote eccentric loading with like heel raises where we utilize the opposite or unaffected leg to help raise up and we eccentrically control the lowering. We want to, again, increase the challenge in our balance and proprioception in order to restore function and safety and promote the performance of agility drills for the ankle's ability to tolerate quick movements and the muscle's ability to fire in response to those quick movements. That is it for the foot and ankle. We will go over the exercises and interventions shown in your textbook in lab. So before you come to class, write down any questions that you have over this lecture so that you can be sure to ask them in class. Cut your toenails and make your feet pretty to have exposed during lab because we will be doing foot and ankle exercises. And review the exercises in the chapter so you have an idea of what we will be performing.